And make sure you guys can see. Can you all see my screen now?
I can, yes.
Okay, perfect. Well, thank you everyone for joining. Let me fix this real quick. Okay. Thank you everyone for joining today. As Anna said, I am really excited to be able to share this information with you today, and the timing could not be better, seeing as Mother's Day is right around the corner, and also May is Maternal Mental Health Month. So it seems like a very good time to be talking about perinatal mood and anxiety disorders. I have a ton of information for you today, so I'll just kind of roll through it all, and if you have questions, put them in the chat box, and Anna, just go ahead and interrupt me at any time. So I just want to let you guys know before we get started, I have no significant financial conflicts of interest that I need to disclose. So just get that out of the way. So just to begin, a couple of quick learning objectives I hope to cover today. I want to cover a broad introduction of perinatal mood and anxiety disorders. Also discuss the effects of untreated mood and anxiety disorders, both in pregnancy and postpartum. I'd like to introduce some screening tools that you can use in your practice. Also review a couple of the treatment options in working with this population, and then hopefully discuss some resources at the end. So one key thing that I want everybody to keep in mind as we go through this, topic is the perinatal period. So the term, the perinatal period, is really an all-encompassing term. And the perinatal period spans all the way from conception, the beginning of pregnancy, through the first year after giving birth. And during our childbearing years, women are the most vulnerable to mental health struggles. That is why we see that that period of time is the highest incidence of mental health intervention over a woman's lifespan. So we see most interventions happening during a woman's childbearing years, particularly in that vulnerable period of the perinatal time. So to start with some nomenclature that I think is really important, I know for most people, they're familiar with postpartum depression. And really what we're looking at in the perinatal mental health is not just postpartum depression. There is a whole group of perinatal mood and anxiety disorders and the term used for those are now PMADs. And PMADs include depression, perinatal bipolar disorders, anxiety or panic disorders, obsessive compulsive disorder, post-traumatic stress disorder, and psychosis. PMADs are the #1 most common medical complication related to childbearing. So I'm going to say that one more time because I am always baffled by hearing that. It's the #1 most common obstetric complication in America. And when we look at that, and we really see the gravity of that, gestational hypertension, preeclampsia, gestational diabetes, these things that we're really familiar with, some of the risks during that pregnancy and postpartum time, their rates are much lower. We see gestational hypertension at a rate of 6 to 8%, preeclampsia at about 6 to 8%, gestational diabetes at about 6%. But the prevalence rate of PMADs in the perinatal period is 21%. So it's really something that is worth talking about. So there's some main risk factors that I want to talk about in the development of PMADs. Some of these include a history of mental health disorders, specifically a personal history or a family history, particularly of a PMAD in previous pregnancies, something that we want to look out for. Also, a sensitivity to hormonal changes can put a woman at a higher risk for developing a PMAD. Things like puberty, PMS, hormonal birth control. And it's important to note that patients with a history of PMDD or premenstrual dysphoric disorder have a much higher incidence of developing a PMAD sometime during that perinatal period. Some other risk factors are endocrine dysfunction, things like pre-pregnancy diabetes, thyroid imbalance, some fertility challenges, things like that can really be a risk factor. We also see social factors, things like inadequate partner or social support, domestic violence, financial stress or poverty, and a recent loss or move that results in some kind of grief reaction. And then finally, another risk factor is high stress families or high stress parenting. We see these in things like military families, teen parents, single parents, parents of multiples, and it's also important to note that single parents are twice as likely to develop a PMAD than parents who have a good in-home support and have a partner to share those responsibilities with. So there's also some compounding factors that are just important to kind of look out for when working with this population. Things like sleep deprivation, pain, breastfeeding struggles, childcare stress, relational difficulty. Sometimes if there's health concerns either for baby, health concerns for one of the parents, sometimes baby's temperament and just disposition can be a little bit of a compounding factor. Some family of origin issues, or even returning to or balancing work. So I want to get now into each of the specific perinatal mood and anxiety disorders. And first I'm going to start with depression. There's a distinct differential diagnosis that I want to talk to you about, actually a couple of them. One of them is pregnancy versus depression, and baby blues versus depression or postpartum depression. Sometimes you can have someone come into your office or into your practice and you aren't really sure, is this pregnancy or is this depression? Is this the baby blues or is this a real postpartum depression? It's really important to be able to piece those things apart. So some of the ways to tell with pregnancy versus depression, one of the things to look at is mood. In pregnancy, we see a labile mood, teary sometimes, but also joy, anticipation, and appropriate worry for pregnancy. In depression, we see a persistent gloom, anhedonia, and less of that joy. With self-esteem in pregnancy, it's usually pretty normal, but in depression, we see it much, much lower, and it's usually typified by a pretty persistent guilt. Energy levels to differentiate pregnancy and depression. In pregnancy, the mom may tire, but rest really does restore energy. But in depression, even when mom is resting and has gotten rest, it doesn't seem restorative, and they may really be experiencing some real fatigue there. With appetite, typically we'll see increases in appetite in pregnancy, and a lot of times we will see a decrease or poor appetite in depression. With sleep, in pregnancy we see waking from full bladder or heartburn or just regular discomfort, but they can fall asleep usually pretty well. And in depression, what we'll hear is patients coming in saying, I can't fall asleep, the house is quiet, I'm supposed to sleep, the baby's asleep, but I just can't fall asleep, or I'm waking up really early and can't get back to sleep. And then finally, suicidality is not normally a part of pregnancy, but certainly can be indicative of some depression, and sometimes some postpartum depression will include that component as well. So the next kind of differential diagnosis I want to talk about is baby blues versus postpartum depression. So the baby blues are something you've probably heard of, and they are totally normal, very, very common. It actually happens in about 60 to 80% of new moms. And the symptoms are kind of crying, feeling overwhelmed, uncertainty, fatigue, maybe being a little reactive, but the predominant mood is happy. So if you ask them overall, how do you feel? They'll say, I feel happy, but I've got these things going on. Baby blues typically peaks at about 2 to 5 days postpartum, and it can last for up to 2 weeks. And that's usually due to an extreme hormone fluctuation that happens at the time of birth, and also acute sleep deprivation really can add to that. But then when we're looking into postpartum depression, we want to look at things like severity, timing, and duration to figure out which one of these we're seeing. In postpartum depression, the symptoms are much more severe. And usually what you'll see is increasing severity. In baby blues, you'll usually see it getting a little bit better over time. Timing-wise, in postpartum depression, with baby blues, usually it's within the first couple of weeks. If it's within the first couple of weeks, it's likely baby blues. If it is after those first couple of weeks, it may be, you might want to be looking at that postpartum depression. Postpartum depression can set in any time in that first year, and sometimes even a little bit after. And then duration, if it's less than 2 weeks, you just want to be thinking baby blues. If it has been going on for more than 2 weeks, then it's likely that we've got some postpartum depression going on. Some of the symptoms of postpartum depression are pretty similar to any depression that we see across the lifespan, sadness and crying. We'll see some unexplained physical complaints or moms who are just having a really hard time healing, or they still feel pain for an extended period of time. Certainly suicidal thoughts can be a part of it. Sleep disturbances that may be a little different than just having a newborn. Like I said earlier, if they just can't get to sleep even when the house is quiet and sleep is available, when they can't sleep, we want to start looking at something a little bit further. Appetite changes, a lot of guilt and shame. A big one to look for is disconnect from the baby or apathy towards the baby. That can be a big indicator. And then one thing that you'll hear a lot in working with this population is you'll have a mom come into your office and say, I just don't feel like myself. I can't get back to me. I don't know who I am. I just don't feel like me. So that's a pretty good indication that maybe there's something going on. With anxiety, again, these symptoms are pretty similar to any kind of anxiety across the lifespan. Sometimes we'll see agitation and irritability. You see kind of that busy body, difficulty, inability to sit still. We see a lot of excessive and persistent worry. That's pretty paramount. Appetite changes and that rapid weight loss, not appetite changes where we're eating more due to stress, but appetite changes that cause a rapid weight loss, and they just can't eat. They just don't feel hungry. We see some sleep disturbance. You'll hear a lot too. I lay down, it's dark, it's quiet, and I just can't turn my brain off. So that's when you're kind of starting to think about a little bit of that anxiety presentation. And then that physical hyperarousal that we see with anxiety. In terms of panic, we see these are just really extreme and often unexplained or out of the blue episodes of anxiety. There's severe physical hyperarousal symptoms, and a lot of times they're confused with a heart attack or a stroke. A lot of times people will end up in the ER from panic. So with obsessive compulsive disorder, something that's important to note is that perinatal women are at a 1.5 to 2 times greater risk than the general population of developing OCD. And it's even higher if there is some kind of generalized anxiety presentation before pregnancy or during pregnancy. Generalized anxiety can kind of blossom itself into OCD, sometimes postpartum. Symptoms include intrusive repetitive thoughts. Usually these thoughts are of harm coming to the baby. Really pretty severe guilt and shame and preoccupation with that guilt and shame, feeling horrified by one's own thoughts. With these repetitive and intrusive thoughts, a lot of times they will be incredibly disturbing, of very graphic things happening to their baby or happening to themselves. There's a hypervigilance, a wanting to protect and keep these things from happening that are going on in their head, and also some compensatory behaviors to avoid their own discomfort or harm to themselves or the baby, or to minimize triggers. So they might avoid situations that are the feared situations in their head, or avoid certain people that they may have been thinking about when thinking about harm coming to their baby. So with post-traumatic stress disorder in the perinatal period, again, these symptoms are pretty similar to any PTSD that you see across the lifespan. Re-experiencing the traumatic event, distressing thoughts, memories of the event. Sometimes you'll have moms that'll wake up from nightmares or dreams. They'll tend to kind of isolate themselves, which at this period of time, we need all the support we can get. An avoidance of triggers, people, places, or things. So they might be avoiding their partner, they might be avoiding their doctor or the hospital where this trauma occurred. You see a hyperarousal and a hypervigilance going on typically. Persistent and distorted blame of themselves or others. So needing to place that blame somewhere, and sometimes it goes on them and sometimes it goes to someone else. We see a diminished interest in activities, and then sometimes difficulty recalling key aspects. So when you're asking them to tell their story, there's parts that are completely and totally blocked out, when maybe if you were to ask their partner, they have that memory pretty clear in their minds. So here are some potentially trauma-inducing aspects of childbearing that could potentially result in some PTSD. Emergency C-sections, premature birth of their baby, postpartum hemorrhage, infant in the NICU, that one's pretty big. That can be very, very traumatic for families. Forceps or vacuum extraction during birth, a 3rd or 4th degree laceration, severe preeclampsia, hyperemesis, or just being very, very sick throughout their pregnancy, a traumatic vaginal birth, and also infant loss. Interestingly enough, the number 1 event out of this list inciting a PTSD reaction is forceps. So the use of forceps is what we found to be the number 1 PTSD inciting event out of all of these. So that was kind of interesting. So to keep going with PTSD, one of the things that if you're going to work with this population, it's really important to take into consideration is birth trauma. This is an event that occurs during the labor and delivery process. It involves actual or threatened injury or death to either mom or to baby. During this experience, the birthing woman usually will experience intense fear, helplessness, a loss of control, and sometimes even a loss of dignity. Some common themes that we see here when you're working with a patient with PTSD from birth trauma, that there are overwhelming feelings of powerlessness when they tell their birth story. Either moms felt unheard or invisible, or they felt like what they were saying was not being taken into consideration. Betrayals of trust, either from their medical provider or from their support systems, their partners. Not feeling protected, feeling like maybe staff or providers dropped the ball or didn't do something that could have prevented harm coming to them or their baby. And also we see a perceived lack of care and compassion. We see that as an overwhelming theme with parents who experience PTSD. A lack of support and reassurance in what's going on. Things can happen fast and furious in labor and delivery, and so sometimes that support and reassurance doesn't happen, and that's exactly what that mama needs at that time. Some feelings of abandonment, if baby's rushed out of the room, or if they have to be rushed out of the room, or certain people are not there with them at the time, there can be real feelings of abandonment. And there are times when you will hear a mom tell a story, or even a partner tell a story where they felt really stripped of their dignity. All of these things can be themes that can lead to a post-traumatic stress presentation. So some of the residual effects of PTSD in the perinatal period are impaired mother-infant bonding, sometimes even an avoidance of aftercare if they feel that, that distrust with their providers, either aftercare for mom or aftercare for baby. Something that's really, really important I want to mention is that PTSD can emerge in a partner who also witnessed the birth trauma. It's really important to assess that trauma in partners as well, because they're standing on the outside and they're watching all of this happen. And sometimes that can be an even more helpless feeling than, being the individual that this is going through. Sometimes, you hear moms say, I just had this Zen-like feeling that this was going to be fine, or that it was eventually going to be okay, but sometimes the partners are not so sure about that. You can see some sexual dysfunction or a hesitance to re-engage in sex with their partner, either for fear of getting pregnant again and going through that again, and that avoidance of future pregnancies, or because it reminds them of the event itself. So there can also be a recurrence or an exacerbation in future pregnancies. So you can get that PTSD reaction again in future pregnancies when they are faced with things that remind them of their trauma and they're triggered in that way. Also, moms who have suffered from PTSD are more likely to have elective C-sections in subsequent pregnancies to assert control or avoid triggers. So now I want to shift gears to bipolar disorder. Especially in the perinatal period, bipolar disorder is widely misdiagnosed as unipolar depression. Part of that is because when you see a patient come into your office and you're trying to make this diagnosis, more often than not, we will see them in a depressed time. We'll see them in a depressed period, and the depressed episodes often come more often than either the manic or hypomanic episodes. But just like bipolar across the lifespan, this is a chronic disorder, has high rates of relapse, suicide, psychosis, and pretty significant dysfunction across settings if not managed well. About 50% of stable bipolar patients will experience a relapse during pregnancy. And about 70% of women with bipolar will relapse within the first 6 months after delivery. One major contributor to those statistics are stopping medications. Stopping medications significantly increases the risk of relapse. So it's really, really important to keep those medications on board so we don't see a relapse of those symptoms. Bipolar is also one of the highest risk factors for postpartum psychosis. Psychosis actually occurs in about 20 to 30% of women with known bipolar disorder, and also about 90% of women with postpartum psychosis ultimately have bipolar disorder. So there's a very strong link there. And this is just a brief overview. You guys probably already know about all of this, but just to quickly go over, but there's the bipolar 1 and bipolar 2 distinction. Bipolar 1 is characterized by at least one full manic episode over a lifespan. Some of these symptoms of a manic episode that are particularly important during this period are, that the racing thoughts and flights of ideas, increased goal-directed activity, decreased need for sleep when, this is time we really need sleep, excessive engagement in risky behaviors, which can be one of the most detrimental parts of a manic episode. And these symptoms are present for at least 1 week, or they're severe enough to warrant hospitalization. And bipolar 2 is, the distinction there is it's characterized by at least one depressive episode, but also one hypomanic episode. With hypomania, the symptoms last at least 4 consecutive days, but may not last a full week. There's no psychosis associated with these, and it's not necessarily functionally limiting. So it can be a little hard to piece out because some people like being hypomanic. They get a lot done. They had a lot of energy and they don't need as much sleep. So now we'll move on to perinatal psychosis. So 1 to 2 in 1,000 women will develop psychosis during that postpartum period. The onset is usually within that first 2 weeks of postpartum. And half of first-time moms with psychosis actually had no previous psychiatric hospitalization. So it can be something that can come completely out of the blue. Some of the risk factors are a pre-existing type 1 or type 2 bipolar disorder, like we talked about a second ago. There's a very significant risk there. Having your first baby is a risk factor for psychosis. When there's an infant mortality, that's a risk factor. Discontinuation of a mood stabilizer also. Any previous psychotic episodes, either postpartum psychosis in the past or bipolar episodes, can put you at a higher risk for psychosis. And family history of bipolar or postpartum psychosis as well. Sleep deprivation is a big one. Sleep deprivation alone can result in perinatal psychosis. So sleep is essential. I talk to all of my mamas that I work with about protecting sleep. We're going to protect sleep like we've never protected anything before, because it's one of the most important components of staying well. So a really quick differential diagnosis that I think is important to note is between OCD and perinatal psychosis, because there can be some really, really disturbing thought processes in each of these. So I kind of just want to show you and go over the difference. So in postpartum OCD, we see an extreme anxiety about these thoughts or images that they're unwanted. There's an awareness that these thoughts are unhealthy and that these things are unrealistic. The mother is usually really disturbed or very fearful of these thoughts, and there's no desire to harm their baby. In fact, the mother has usually taken some pretty dramatic steps to ensure that baby stays safe. There's no delusions or hallucinations in OCD, and you'll hear moms with a significant concern about going crazy or losing their mind. It's a really, really worrisome thing for moms with OCD. But with postpartum psychosis, there's not as much anxiety that you'll see. There may even be some aloofness about some of these things that they're thinking. There's a higher tendency to act on these thoughts or indulge in these behaviors. There's not a whole lot of recognition that these thoughts are unhealthy or unrealistic. There's often some delusions and some hallucinations. One common one is that there's a strong belief that their baby is either demonic or possessed, which can then lead to some thoughts of harming their baby or even a desire to harm their baby. So a couple key notes with this, almost all postpartum psychosis preceded by insomnia. So we talked about sleep being so important with this. You might have a partner come in and say, you know, she's just not able to get to sleep at night. She's really busy doing some really interesting projects, and she's just not sleeping at all. So that can be an indicator that there might be something coming. Also, treatment requires immediate attention and crisis stabilization, often hospitalization. We want to have treatment by, or at least consultation with, a reproductive psychiatrist whenever possible. And this typically requires medications, intense sleep therapy, and close monitoring. So this is something we really want to get on top of pretty quickly. Okay, so now I want to move to some of the effects of untreated PMADs, so both in pregnancy and postpartum. Some of the effects of untreated depression during pregnancy are poor self-care during pregnancy, poor nutrition, poor sleep, an increased risk of suicide, negative effects on bonding with the baby while in utero, a non-compliance with prenatal care, and we all know how important that is. And also, untreated depression has been linked to preterm birth, low birth weight, development of preeclampsia, and even gestational diabetes in mom. Some of the effects of untreated anxiety in pregnancy are increased cortisol levels both in mom and the fetus. It can also be a disruption of the developing brain circuitry and hormone systems in the fetus. And also it's been associated with preterm birth, shortened gestational age, and low birth weight. Some of the risks of untreated bipolar, particularly that mania phase in pregnancy, are the consequences of these risky behaviors. So consequences of unprotected sex, exposure to sexually transmitted diseases, increased risk of substance abuse or use, decrease in self and prenatal care, and often a pretty unrealistic preparation for baby. So some of the effects of these PMADs in the postpartum period are, with depression, we see moms who are depressed, we see a difficulty in breastfeeding. In fact, depressed moms are much more likely to breastfeed for shorter durations. They also tend to report breastfeeding as more of an unpleasant and negative experience than non-depressed moms. We see an increase in sleep disturbance in moms, and that's outside of just having a newborn. We see poor self-care with infant, but with self, and then also poor infant care for the baby. Difficulty with bonding and attachment with the baby. Decrease in adherence to follow-up appointments. And you know, anyone whose parents knows that there's a lot of appointments after baby comes, and that are really, really important to ensure that baby's thriving. So what we see is a decrease in the adherence to these appointments when mom or dad are depressed. So there's also some risk for baby when we see untreated depression. Some of these risks include decreased levels of dopamine and serotonin. We've actually been able to measure that in newborns. Increased crying. These babies tend to be harder to soothe, which can exacerbate depression in the parents. Also, a delayed fetal heart rate responsivity has been shown to be connected with untreated depression. And this one is really interesting to me, that the brain activity of a baby who has been exposed to depression either in utero or after postpartum really mimics that of a depressed adult. So there are really pretty significant effects both for mom and for baby when we're not treating these things. Some of the effects of untreated anxiety in the postpartum period include increased sleep disturbance in moms, again, increased risk of developing OCD, some fertility issues as well. And I know this is not in the postpartum period, but anxiety can be a real barrier to fertility. It suppresses because of the sympathetic nervous system response, it can have a suppressing effect on your reproductive system. So a lot of times it can actually interfere with fertility and a person's ability to get pregnant. Some of the risks for the baby with untreated anxiety are we see an increased fight or flight activation in the babies, including an increased startle response, increased difficulty in these babies to learn new tasks, increased anxiety and fear in children, in infants and into childhood. These babies are also harder to soothe, which can exacerbate the anxiety as well. And then we see that persistent elevation of cortisol could disrupt the developing brain, causing an effect in the hippocampus, amygdala, prefrontal cortex that ultimately can impact learning, memory, and emotional and behavioral adaptation. So some real effects here when we're not properly treating these disorders. So now that we know what the disorders are, we'll move to screening. Screening is a really important part of working with this population. Again, just as a reminder of the prevalence of these perinatal complications, we screen for all these other things. We screen for hypertension and preeclampsia, gestational diabetes. We need to be screening for PMADs as well. There is a much higher incidence of these things, and they can be just as detrimental. So big question is, who can screen? And the answer is anybody that interfaces with a parent or pregnant or postpartum mom can screen for this stuff. OBGYNs, primary care, doulas, lactation consultants, pediatricians are a really, really good place to get that screening in because most healthy deliveries after mom gives birth, she will see her doctor 6 weeks later, and that's it. But we see the pediatricians a lot more often. And so adding those in with babies appointments can be really, really helpful in getting women screened. So I want to introduce a screening tool that I think is really great. It's one that I use in my practice, and it's actually the one that I've seen used around our area most commonly. It's called Edinburgh Postnatal Depression Scale, or the EPDS. Can be used both in pregnancy and postpartum. I use it in both. It's a quick 10-item self-report assessment. It's free to download and use. You can Google it, you find it really fast. Print it out and start using it today. It's meant for screening purposes though, just to note. It's not necessarily diagnostic. So we really want to look for a score that's higher than 10, and that warrants either more investigation or a referral to a mental health provider. And I wanted to share a study with you guys that I think really highlights the importance of screening. There was a study done in 2000 where 391 outpatients at an OB practice were part of this study. The women were screened using the EPDS, and with screening, the rate of detection of postpartum depression was 35.4%. The rate of spontaneous detection without screening was 6.3. There's a huge disparity between how well we're able to identify these issues with screening and how well we're able to just pick it up. Sometimes our patients, sometimes our moms are not going to tell us that they're not doing well because there's a lot of shame involved in that. So when you can give them something that helps to kind of normalize that and pick up on that, it can be really, really helpful for early detection. This is the EPDS. If you haven't seen it before, like I said, quick 10-item assessment, really quick. Again, Google it, you can find it and start using it ASAP. Okay, so let's move to treatment. I will kind of breeze through this because I don't want to run out of time. But like most things, the best treatment for PMADs is prevention. It's important to let your patient, and when you're working with someone in the perinatal period, to let them tell their story. This part is very, very important. Sleep hygiene is key. I've said it before, I will say it again. This is primary to keeping someone well. Psychoeducation is really, really important. Unfortunately, this is not something that we talk about a lot, or even a lot of moms know is so prevalent. So psychoeducation is important. Keep your mind open to the idea of medications as treatment and using medications when necessary. Assess and utilize all of their supports, not only professional supports, but also support outside the home. When you have a new baby, you can use all the support and help you can get. just remember, every patient's in a different place. There's different strengths and weaknesses that they bring to the table. They need something very specifically tailored to them and their specific circumstances at the time. And make sure to be aware and sensitive to any cultural considerations that they bring to the table, because that can make a big difference in how you treat these patients. And then lastly, consult often. Work as a team whenever you can with other providers, particularly if there's a prescriber involved. So some of the psychotherapeutic approaches that are useful for working with PMADs are CBT, ACT, IPT, motivational interviewing can be helpful, peer support groups, either a group or individual, psychoeducational groups, or mother-infant therapy and education. So a quick overview on CBT. This is effective for treating depression, anxiety, OCD, panic, and trauma. Casts a pretty wide net. CBT is based on the assumption that thoughts create emotion and emotion dictates behavior, or at least influences behavior. So in CBT, you're really teaching the patient to learn to recognize, evaluate, challenge, and change these irrational thoughts through a process called cognitive restructuring. It also includes teaching or modeling some positive behaviors, such as calming techniques, relaxation techniques, improved self-care, improved self-talk, things like that. Keep in mind, though, that this requires a baseline ability to rationally challenge their own thoughts and behaviors. And if somebody comes in to work with you and they're in crisis mode or their basic needs are not being met, it's going to be really difficult to go to this kind of higher level modality before making sure that those things are taken care of. So some common themes that might come across in your office or when working with this population that would give you an indication that CBT might be appropriate. With depression, they might be endorsing thoughts about themselves as parents or their ability to be a good mom or a good dad, thoughts surrounding the loss of their previous identity. With anxiety, panic, or OCD, sometimes they'll bring to the table these irrational fears surrounding harm coming to the baby, either through germs, medical concerns, sometimes these irrational fears of kidnapping and abuse. In anxiety, we tend to overestimate the level of danger and underestimate our ability to cope. So we really want to help them work through that cognitively. And also it's important to educate them that thoughts do not equal the truth. This is particularly important in depression and anxiety, but also thoughts do not equal action. This is particularly important in OCD, that just because they have these disturbing thoughts does not mean that they're going to do it, does not mean that they're going to act on it. Thoughts are not actions and thoughts are not always truth. And in a trauma, one thing that could lead you to believe CBT is appropriate modality is bringing along or bringing out their assessments of the experience. Is their assessment of their experience and their trauma, how accurate is it? How helpful is it? The assessment of their own resilience and their own ability to cope, which usually is an underestimation. And sometimes it's helpful to re-story or redefine, retell the event itself in different terms. So with ACT, this is born out of CBT, and basic tenet is the acceptance of one's current circumstances, and also a commitment to responding and behaving in a way that's consistent and in service of their own value system. It's effective for treating depression, anxiety, and also trauma. Some common themes that you might see in your practices that would lead you to believe that ACT might be an appropriate modality are just some general parenting struggles, decreased sleep and time for their self and partner, demands of an infant, drastic changes in lifestyle, things like that that really kind of warrant some acceptance and moving in the spirit of their own value system. Also, when we see unwanted and unanticipated components of parenthood, like difficult medical issues or diagnoses that they're dealing with, sometimes developmental concerns with baby, ACT could be really effective. And also with birth trauma, accepting the event and accepting the aspects of the event and being able to move forward from that in service of their chosen values. For IPT, some things that might come across in working with this population that leads us to believe maybe interpersonal therapy is appropriate. And we can particularly use these when there's depression and also relational conflict. It usually involves communication training, modeling effective communication. You can do some couples and family therapy, role playing, resolving grief is really important component of IPT, strategizing those new role transitions, and development of new and healthy social supports, not just their partner or their immediate family, but really developing a wide support net. Some common themes that come across in the office are conflict with their partner, either with new roles or division of responsibilities, which can be hard to manage, intimacy issues, conflict with others that comes up with things like blended families, other family members or in-laws, the kind of revolving door of guests that comes when there's a new baby in the home, and then also, again, that lack of social support. So motivational interviewing, it's used when a patient is ambivalent to the change that would produce a benefit and increase wellness for them. It utilizes psychoeducation, assessment of goals, and appropriate goal setting, teaching the patient to goal set appropriately, and encouraging specific goal-directed behaviors. Some of those common themes that might come across in your work with this population are the use of supports. So functional supports, emotional supports, and informational supports. I use these three kind of categories of support. Functional supports being who are the people that are going to help you do things, who are going to help you functionally, who's going to help with the midnight feedings, who's going to bring you dinner or cook you dinner, who will be the person that can come over and take the baby for 15 minutes so you can take a really long shower. These people can be family or friends or even hired help, but we want to assess that social support. Emotional support, these are who are the people that you can call and cry to, who are the people that you can get, that you can commiserate with or get advice from or just talk in a safe environment. And then informational supports, these are the people that you get your information from. Typically it'll be your therapist, your medical doctor, your baby's pediatrician, a good book or two that we really trust. Google, which it can be dangerous at times. I think we all know that. So if you have a parent or a mom that is really big on looking everything up on Google, you might want to guide them to be really discerning about the information that they're looking at. Mommy blogs don't always help decrease our depression or anxiety about things. So making sure that we're assessing those supports is important. Also, uses of medications and therapy might require some motivational interviewing. Sometimes medications are necessary. Pregnant and breastfeeding moms are typically pretty hesitant to put a chemical in their body because they're worried about the effects and they've heard that everything is bad. But it's important to try and help them understand that there are a lot of benefits as well. Using motivational interviewing to help a parent increase their self-care, since our own self-care goes to the bottom of the priority list once we have a baby. It's important to help encourage them to do that, and maybe some parenting behavior change. Tread lightly with this, but also if there's a concerning parenting behavior, you want to be able to talk with them in a safe way. So I want to breeze through this as well with medication considerations. I think probably most of you are, I'm going to assume most of you are not prescribers, myself included, but I want to talk to you a little bit about how to support medications in working with this population. So we always go off of a risk-reward model. Exposure to a risk is inevitable. There is exposure in treatment, and there is exposure and risk in illness, right? So whether we treat it or we don't treat it, there is exposure and risk. Our most critical window, like we talked about, that most vulnerable period is between 36 weeks of gestational age and 4 weeks postpartum. And what we see right after birth, there's a rapid drop in estrogen within the first 48 hours after birth that results in a dramatic drop in serotonin levels too, which can affect mood and anxiety. Also, at the same time, an increase in dopamine, which can really lead to that risk of psychosis and in that critical window. So some quick guidelines for supporting medication usage with your moms that you're working with. Psychoeducation and interdisciplinary collaboration are key, so work with as many of their providers as you can. Monotherapy whenever possible, one medication if possible, to decrease the risk or to decrease the exposure. If it's working, with medications, don't change it. Maximize non-pharmacological interventions first. which includes psychotherapy. If a patient that you're working with becomes pregnant while on medications, do not encourage them to discontinue their medications if the medication is effective and if the patient is well. That risk of relapse really skyrockets when we discontinue medications in pregnancy and postpartum. So in choosing medications, what has worked in the past, what's working now, we want to consider some of the side effects. To continue these clinical guidelines for supporting medication usage, just good to note that Zoloft or sertraline is typically the preferred pharmacological treatment for depression, anxiety, and OCD, although patients with OCD usually require a higher dosage to acquire remission. We do not want to encourage tapering off of medications as delivery approaches. Sometimes you'll hear that as, well, maybe we can start to get off this before baby comes, but 36 weeks gestational age to 4 weeks postpartum is the most critical window. So that's the time when we need these on board the most. It's the height of our psychiatric vulnerability. So really, the opposite is what we want to be looking at. So either considering increasing dosage at that time or starting a medication altogether for women with a history of PMADs. Also encourage patients to take their medications as prescribed. You want to increase efficacy and decrease double exposure. If you have a patient who is kind of taking their meds or is taking will only take the dosage that's the very, very lowest, what can be happening is they have a double layer of exposure. So not only are they getting the exposure to the medication, but they're also getting exposure to the illness because the illness isn't being treated. So now we've got a double risk there. So some complementary interventions that have all been proven to show benefit in pregnancy and postpartum and decrease depression and anxiety are prenatal massage, yoga, acupuncture, exercise, nutrition, lactation consultants, even bright light therapy can be really helpful. Again, social supports, this part is really important. We want these 3 types of social support assessed and encourage your patients and your mamas to use their functional supports, their emotional supports, and their informational supports. You can find them through family and friends, faith communities, in peer support groups. Both hospital systems in Boise offer a wide variety of pregnancy groups and also postpartum groups that are really, really wonderful. So get them linked in with that. Telephone support. There's an organization called Postpartum Support International we'll talk about in a second, and they have a warm line that's a 24-hour line for mothers and families. So that can be really helpful. And also online support, Facebook groups or meetup groups, or there's a Peanut app. I don't know if you guys heard of that. It's called Peanut, and it's kind of like Tinder for moms. You can read bios of moms and their kids, and if it seems like it's a good match, you can meet up for a play date. And I've actually had some patients who've had some good success with that. So just to kind of round this out, the key points that I want you to take home with you are that the perinatal period, remember, that includes all of pregnancy all the way through the first year after the birth of the baby. And this one's a big one. Untreated effects and the risks of perinatal mood and anxiety disorders will often outweigh the risks of treatment, including medications. Thorough screening is key, and it's a pretty simple process. It can be a pretty simple process. I've said it before, again, consult. Work with the professionals whenever possible. If you have someone who's prescribing medications, make sure to collaborate with them. If you work in a collaborative environment, you will see better outcomes. And then also remember and remind your patients that these disorders are treatable. It's not their fault. They didn't choose this, and they will be well again. And with treatment, they will get back to their baseline functioning. So that part's really important to instill that hope. Couple of resources just to throw out there, some local resources that I think are really great. The Idaho Infant and Toddler Program, it's not just to support infants and toddlers, but they also support parents and families that need a little extra help. Idaho Parents Unlimited is to help the parents and families of kiddos with some developmental disabilities. St. Luke's and St. Alphonsus, again, they have great resources for pregnant and postpartum families. Use them, get your people linked in with them. And then here are some here are some more broader, or a broader resource. I talked a little bit about Postpartum Support International. This is an organization that's main goal is to increase education, awareness, and resources for pregnant and postpartum families. There's a toll-free 24-hour helpline for women and families. The number's there. I believe Anna's going to email this stuff to you guys as well. Phone number's there. They have it in a couple of different languages. Postpartum Support International also offers a perinatal psychiatric consultation line. So for those of you who are not prescribers and medical providers, this isn't going to be something that you would utilize, but if you're working with a prescriber that is feeling a little uneasy about what pharmacological route to take, they can call this number and they can talk directly to a reproductive psychiatrist to help kind of get this figured out. It's a great resource. And then the website there for Postpartum Support International is on your screen. And then some other medication resources. We've got Mother to Baby, Infant Risk Center, and Massachusetts General Hospital Women's Mental Health Center. These all are resources for providers and for families to look at risks of medications and risks of untreated illness and just tons of resources, tons of information to help people navigate this time period. So that's all I've got for you. I want to open it up to questions.
Yeah, if anyone has any questions, they can just go ahead and type them into the chat box and I can read them out for her. So we'll give it a few minutes.
Okay.
And like Dr. Root said, I will be emailing everyone who registered for this webinar these resources on her final slide. Okay, I'm not sure. I'm going to wait a little bit longer just in case people are typing.
Okay.
Oh, here we go. We have a question from Bryn. It says, are there websites that you can refer to a doctor who is encouraging mom to taper off meds closer to delivery?
I think I heard that. Are there websites that you can refer a doctor to who is encouraging a mom to taper off?
Yes.
Is that? Okay. Yeah, that's an important question. It's interesting that you'll see a lot of doctors still will kind of go with that. It's an old kind of train of thought that we should taper off closer to delivery, but really the research tells us the opposite. So I would use that psychiatric consultation line again, because they can speak directly to a reproductive psychiatrist, or even any of these resources, websites that I gave you today could be really helpful. But when I work with the medical providers that are also working with my patients, I make sure to give them that psychiatric consult line every single time because it's an incredible resource.
Okay, any more questions? We have another question from Cassandra. It says there is a list of counselors. Oh, is there a list of counselors in the Treasure Valley who are practicing working with the perinatal population?
There is, so PSI, which is Postpartum Support International, has an Idaho chapter, and there is, you can kind of get to that from their website. There's a list of providers. I don't think it's very long right now, just because the chapter is pretty new in Idaho. But also, I mean, if you need, I have a list of people. If you guys are welcome to either email me or call me if you have any questions. I can help provide a list of providers in the Treasure Valley. There are even like these bigger, I'm sure most of you are familiar with today. I know that working with pregnant and postpartum women is one of the specifiers as a specialty on there. So that might be like kind of a broader resource.
Okay, yeah. So one more question from Wavy Tech says, along the same line, are there any local perinatal psychiatrists?
No.
No.
Unfortunately, there are not that I know of. I'll say no, not that I know of. I'm fairly sure that there are not. I know that there are some doctors that are more comfortable and maybe a little more up to date on some of this information. But as far as a reproductive psychiatrist, there isn't one in town that I know of. I know over in if you have someone who really, really is needing to work with a reproductive psychiatrist, I know it's kind of hard to get them resources that are not local. But at OHSU in Portland, they have a Center for Reproductive Psychiatry that is one of the main reproductive psychiatrists there is Dr. Nicole Serino, and she is incredibly brilliant and very knowledgeable about this stuff. So it's a close resource, but it's not local.
Mm-hmm. Someone is requesting to have your email address, Dr. Root. Do you want me to include that in the email I sent out? Yeah, so I will include Dr. Root's email address in the email I will send out to all the people who attended the webinar.
Perfect. And you guys are welcome to, if there's, someone that you're working with or you need someone to work with. I have, I am mostly only taking, this population. So if there's somebody that you really need to get in for treatment and for psychotherapy in this population, feel free to reach out to me. And if I can help, I will.
Awesome. So if there are no further questions, I think we're going to wrap it up. Thank you so much, Dr. Ruth. That was awesome. I really enjoyed your presentation, and I'm glad that's recorded so we can share with more people in the future as well. I want everyone to look in their inbox within the next 15 minutes or so for that email that will have the list of resources along with Dr. Root's email. I also put the Empower Idaho newsletter sign up in the chat box so that you can hear about our future webinars we have coming up. I just want to thank you again, Dr. Root. That was great. So thank you so much.
Absolutely, and thank you.
I hope you have a good rest of your day.
You too.